You're listening to the Biohackers World Podcast.
Hello, I'm Jason Pencek. I'm here at the Biohackers World Conference. I'm a nurse practitioner and chiropractor, has a clinic in Chicago, and I'm here today with Dr. David Karli. He is the owner of Greyledge Technologies. They do a lot of AI-driven technologies with PRP, so platelet-rich plasma, and bone marrow concentrate. So I'm thankful you're here today. Thank you for joining me.
Great to be here, Jason. Thanks.
Thank you, and I'm actually really excited. I use PRP in practice. I've used bone marrow concentrate. What got you into doing these two therapies or cell-based technologies?
Well, it's been a long journey, over 20 years working at this stuff, but I was traditionally trained interventional pain guy.
Yeah.
And realized very early in my career that the tools that I had at my disposal weren't solutions to anything. At best, a Band-Aid, and they worked extremely well for very short periods of time. So that led me into researching alternative methods. I ended up in Europe and all over the place. It was quite a slow evolution, but around that time, we ran into some old dental literature about this thing called platelet-rich plasma, way back in the early 2000s. And one thing led to another, but got involved in that, but then realized as we did that there was a quality control problem, a big one. Right? It was more magic than science. So what we've looked to do over the last 20 years is really add an element of quality control to biologics, to think of cells in terms of dose and predictable response. Because otherwise it was kind of a roll of the dice, right? Put it in there, let the magic happen, maybe it helps, maybe it doesn't. So we've been working on making biologic products and outcomes predictable. If you can predict it, then you can know where to use it and how to adjust it over time.
Amazing. What is the biggest misconception practitioners might have about PRP and other cell technologies, bone marrow concentrate? What are you seeing as the biggest issue with, obviously people like me being like, well, why do I use you? What's so special? Or what's the misconception that really you want to correct that people have?
Well, there's a lot of them. I think if I had to choose one, it's a physician and a consumer issue. And that is really our whole MO, and that is if you treat 10 people, right, 7 or 8 tend to get better, but those 2 or 3 do not. Why? Right? So we've tried to answer the why, and what it comes down to is really understanding if you make 10 PRPs in a typical commercial system, you'll get 10 totally different final products. There's no standardization. So the biggest misconception is what's in the syringe. If you don't know what's in the syringe, how do you know if the product you're giving to that patient is optimized, is going to give them the best chance for return on their investment? These are expensive things.
Exactly.
So I think that's what we've worked really to try to put some data around to make it, for practitioners, more predictable. So you can counsel your patients more effectively if you know a dose and you know an expected response.
So when you talk about the cellular dose, what does that mean? That's the big thing with Greyledge.
Well, and it's still being defined. I'll add. We started with how many cells are there, right? So there's layers of dosing, if you will. So, but these are what we call heterogeneous products. What that means is there's lots of cells involved. It's not one cell. So they all work together with the body to produce a therapeutic outcome. And we had to think about dose in terms of all of the cells, not just one type. Like PRP is platelet-rich plasma. It's not just platelets that are producing an effect. So we tried to break it down first at the cellular level. What's the cell composition of the product that's going into the patient? And then we put that into a database and track it with outcomes, how the patients are responding to that dose. And thousands of times later, we're able to learn what works and when and for whom. So that's layer 1. Layer 2 is what the cells release once they go into the body, right? They react to an environment and release their products to produce an effect. Layer 3 is the one we're really excited about. I'll talk a little bit about in a few hours, the genomics layer. What genes and epigenomic influence on the genes are leading to that release of proteins which produce the effect. And if you can, we're code breakers. We're biological code breakers. We're trying to piece all of that information together in order to say, Mrs. Jones, we've treated 873 people with your problem. When we make this biologic product, then there's an 82.6% chance you're going to get a good effect. That's what we're driving towards.
I love that. So we're using AI technologies to help figure that out for patients.
Well, it's so complicated, right? There's hundreds and hundreds of variables that can go into, predictive variables that can contribute to outcomes. So we have to consider all of them. And the only way to do that was with an AI model that can do A plus B plus C, A plus R divided by F plus X over A squared, right? You know, it's crazy. It's just insane number of connotations, and we have to consider all of them continuously and then on a rolling basis, because what we learn today may be different as more data comes in. So it was a match made in heaven for an AI model. It was really a question of getting the coding done that could account for all of those variables and actually make some sense out of them.
Of course.
It took a long time.
So when you're obviously teaching practitioners or even talking to patients, how do they know, should I be doing PRP, should I use the BMC, which one should I do? And obviously you're probably telling them the effectiveness of each one. How would I know as a practitioner? And then obviously as a patient, it's going to come to you and say, David, how do we do this?
Yeah, there's kind of two layers again. So my own experience as a practitioner as well, we kind of lay that down, and patients ultimately have a choice, but we try to use data wherever possible. So we have 5,300 treatments in our database. So we fall back on that. If you have a partial thickness rotator cuff tear, well, let's look at those and use that to influence our decision. As a general rule, anything that's going into a joint, an arthritis type of model, we're typically recommended cells, bone marrow concentrator stem cells isolated from the patient's own body. For routine tendonitis and soft tissue problems, bread and butter orthopedic stuff, we'll often use PRP. The only caveat is if it's a chronic problem, sometimes you got to do it more than once. Sometimes you got to hit it a few times. And again, that's a dosing effect. But as a general rule, that's kind of how we approach it. But a real severe tendon problem might be better with cells. So it's really a case-by-case basis. You can use a combination of wisdom and data kind of piece together to make your decision as to what's best.
And I guess that's kind of the next question here. So you run a clinic in this biotech company, and so you're doing research, and you're also doing frontline development. How do you basically help clinicians like me know when this? Because you have all the research, and I'm sitting here like, well, I don't really even understand when I should be using this. What data do I need to bring to you to help me figure out what to do?
Well, the cool thing, when we partner with a practice or a hospital or whatever, they participate in our data program. So we want you to collect your own data over time, so you can counsel your patients based on your patient population. Now, there's the collective body of data that we all gather that we can draw from, but it's really kind of about becoming part of the solution, really. Right? The problem was not knowing, rolling the dice, hoping people get better. Some do, some don't, but we don't know why or how to make it better. When you partner with Greyledge, we're able to include your data, but then also you create your own database. And we want you to use that to counsel your own patients. It's a natural confidence that they gain in you when you're able to counsel them with your data. Hey, here's what we're seeing, not what the field is seeing or what published studies are seeing. Here's what we're seeing in our clinic, with real people like you. So wherever possible, we try to get to that point where we can make decisions and counsel patients to make a good decision based on real data and real patients.
I love that. What's the timeline? For example, I do a PRP on a patient. They come in on a Monday. How long do they expect before they're feeling any better?
Too slow. One of the challenges we're working on, the data on biologics is excellent, but it's also slow. And people are used to things like steroidal injections where they may have a response in 48 hours, very, very fast. One of the problems with steroids is they work really well and really fast. So we have to counsel somebody, hey, it might be 4 to 6 weeks before you start to see your effect. Well, what do you do in that 4 to 6 week time frame? It's a little bit of a void that we're working on, and we're working on actually isolating proteins in the blood which may act a little bit faster than the cells, and looking at combination therapies and things like this. As the field evolves, we're hoping to come up with a solution. But if you look at the database, the 1 month time point, because we track people over 2 years, the 1 month time point, most people have some effect, but the better one is the 3 month. That's a long time when you're hurting. So we really have to work with them, and we have to kind of coach them, hey, hang in there, it's going to get better, because a lot of times you'll get a call 2 weeks out and you say, Doc, I'm not better. Is everything okay?
This didn't work, oh my God.
Totally normal, right? So that's one of the hardest parts about biologic and cell therapies, I think, is working with the patients to manage those expectations. If they hang in there, most of them will get better. But if it's a surgery option on the line, sometimes they aren't able to wait long enough, and they end up with a surgery in a biologic that would have actually worked had they just hung in there.
It's really rough.
So it's something we have to work very, very hard and maintain communication with them, and maintain that line of communication so that we can let them know, hey, it's normal to not have a home run at 3 weeks. right? So that's one of the biggest challenges, I think, and one of the things we try to counsel practitioners getting into the field is you've got to change your mindset. It is a totally different animal, and we're playing the long game here. This is not a short-term solution. You know, when we talk to patients about cell therapies, they often, is this a once and done? Are you looking at multiple? And we say our intention is to do one treatment and get at least several years, plural, several years of improvement out of a single application. That's our goal, to make this cost effective. That's the kind of outcome we want. If someone gets better for 6 or 8 months, that's a failure in our mind. So that's a whole nother mindset shift that has to go into practicing this medicine really well.
So how often would you repeat? I mean, a PRP or a BMC, like are there protocols every 3 months I'm doing the PRF or PRP? How many months before I repeat a PRP treatment or a BMC? Is BMC just one and done? Obviously it's a little bit stronger. Obviously we should talk about that. Which one's stronger, right? The PRP or the BMC?
Well, I think, in combination of the two, which is another thing that we're looking at. Now that's a really fascinating thing, because when you combine the two, because bone marrow naturally has a lower platelet count than peripheral blood, than venous blood. So when we make a bone marrow concentrate, it's also PRP, but it's a much lower platelet count than if we made a PRP from blood. So we're adding things back now. It's just a sum game. It's the number of white cells, and the number of stem cells, and the number of monocytes, and the number of platelets. That all gets plugged in as our dose. And it's about identifying what is an optimized dose for a specific problem. But to answer your question, I try to dissuade cookie cutter protocols, unless it's a unique circumstance like an athlete or a traveler or someone flying in to see me. It's more kind of let's see how it goes and decide. If you get a partial responder, and I would say I would like to wait at least 6 weeks before making that decision.
That's more the minimum,
Because sometimes I hear protocols, well, we do one and then we do another 3 weeks later. Well, if you had waited, that patient might get better. So sit tight. So because it's kind of a slow rollout, my recommendation is follow up at around the 6 week mark. Make it, and the decision might be, hey, let's hang in there. If they're getting better and their improvement curve is on the upswing, hang in there a little longer and wait. You might get your outcome with a single intervention. Saves that patient a lot of money. So I wouldn't rush, but sometimes the patients want it. Right? Hey, I'm better, but you know what? Let's do another one.
Let's go.
You got to just kind of weigh that on a case-by-case basis.
And so we really think we should probably explain is the difference between PRP and BMC, because I think a lot of people are obviously very confused. We're talking about these terms, and everyone's probably say, well, why am I doing a BMC? What is this bone marrow concentrate? Why do a PRP? Please help me educate.
So platelet-rich plasma, or PRP, is a product that we isolate from one's venous blood. So from a vein, do a blood draw from a vein. And we isolate and concentrate the platelet fraction of the blood. Platelets coordinate healing under normal circumstances. But we also can make different types of PRP. We can add white blood cells back to it or take them out depending on the clinical situation. But the white blood cells also play a role. It's a combination of things. Again, it's a heterogeneous product. So PRP is a concentration of peripheral or venous blood products that are used to trigger and stimulate healing. Bone marrow concentrate is a PRP-like product, but also contains what we call progenitor cells. Now, the word stem cell is a very generic term. We say there's stem cells in there, and there are, but progenitor cells are many types of cells that have therapeutic capacities with stemness. Right? Stem cell isn't one type of cell. So when we harvest from bone marrow, we get lots of progenitor cells, which we concentrate, and then we also concentrate our platelets. So we get the benefits of PRP, and we get the benefits of bone marrow progenitor cells in one product that's implanted similarly. A little bit more punch to a bone marrow concentrate than a PRP. Again, you weigh the situations as to use which and in what circumstance.
Well, then I guess the next question is, how often do you use them together? Can you use just BMC by itself? Obviously, I mean, I've used PRP in practice before. That's a by itself product pretty often. But how often are you seeing BMC being added to PRP? Is it obviously probably more useful to add the PRP? When would you decide to use one versus the other?
The more I do it, the more I'm thinking we should do it all the time, because the data's proving that out, which makes sense because you get, what you get out of the cells, right, the progenitor and stem cell fraction is a little bit different than what you get out of the platelets in terms of what's released. Because platelet count in bone marrow blood is lower, why wouldn't we add more platelets back? So, I did bone marrow concentrate for years by itself, and the outcomes were excellent. But because about 70% of my patients fly in to see me. So I don't have 3 treatments or a long period of time to work with them. We have to try to get it done as much as we can in one session. So we said, well, hey, platelet count's naturally low. Why don't we add some platelets from peripheral blood? It's fairly easy to do. And then measuring, check our dosing and track all that. And the data is showing that we get a little faster response, early data. And we're going to wait to see if we get a more sustained response. That's unclear because we got to track these people for a long time. But my sense early is that we're going to get both. We're going to get a little faster and a little stronger, longer response, in which case I don't see a reason why we wouldn't combine them together.
So would that be, again, let's say money is an object. Your patient comes in and says, I don't care what it costs me. Would you do BMC and PRP on every single person you saw? Or is there a reason to do just PRP instead of just BPC?
Yeah, for bread and butter problems, if someone comes in with a tennis elbow or an itis, right? I call them the itises, right? So acute or subacute itis, something that hasn't been there for 5 years. I think PRP still works great. For really chronic or severe soft tissue problems, or what I get a lot of, which is arthritic issues, moderate to advanced. I wish we got people sooner, but I'm not getting them until they're very, very symptomatic. So they're middle to end stage. That's when we're able to intervene. I think it's more of a cell play, more of a bone marrow concentrate play in those situations. We're just seeing, it's not that PRP doesn't work, but we're seeing a more sustained effect with bone marrow when we're doing bone marrow for those problems than we are with PRP, which you have to repeat often. So with a traveler, you don't have the luxury of being able to repeat it. So bone marrow will get you a little bit better carry in those circumstances, but it's also a more involved and more expensive procedure. So there's a lot to consider when you're making these decisions.
Now that'd be the next thing. So we said PRP at 6 weeks you're checking up. How long before BMC do you check on again? Like, hey, is it longer now?
I don't want to hear, right? Wait, right?
Yeah,
as
just
long
wait.
as possible.
That's the thing,
right? Because again, that's really a long game effort, and we have a unique system. So electronically, we collect outcomes on our patients before their treatment, and then 1 month, 3 months, 6, 12, 18, and 24 months. So we've almost fallen back on our electronic outcomes measures as our follow-up. I really don't want to talk to the patient because they're going to want to talk me into doing a second intervention.
That's how patients are, though, right? They're like, doc, when can I come again? Let me do the next one. You're like, wait a little bit longer, please.
Hang in there. So you find yourself doing that a lot. So we didn't do that by design, but we almost fall back on, hey, look, you're trending up. Your outcomes are trending up. Let's wait. We might get there with one. So it becomes in part a financial issue too, right? Because we want this to be value, productive to patients. So it's expensive, and we don't want to do another intervention too soon. If we had waited and got our outcome, then we saved that person a lot of money.
Are you looking at any data on what their CRP levels are or anything? Is that brought into inflammation? So you're seeing how does this product work with a higher CRP inflammation marker versus lower? Does that data come into play at all?
Great question, and we're starting to. We had to really get a handle on kind of that first layer of cellular dose and response, and that it just took a long time to gather enough data to make it work. As we go now, we're starting to think about the genomic piece, and we're starting to add biomarkers and all of the biohacker resources. Anything that has a measurable dose can be tracked as a predictor. So one of the things we're very interested in is hyperbaric protocols before and after. All orthopedic tissues are avascular. They don't have any direct blood supply. So there's no oxygen that gets to them. If we can drive elemental oxygen into those tissues with hyperbaric oxygen therapy, we're going to help stimulate repair and healing. So we see a perfect synergy there. That's one example. There's lots of others. But we see a perfect synergy there because of this unique tissue that has no direct blood supply. It's at risk to degenerate and deteriorate. Let's drive oxygen to it with our cells, and we should get a 1-2 punch out of that, but we're going to have to see how the data plays out.
I guess it's the next thing. What are you counseling patients on doing before they come and get a PRP or BMC? Because obviously you want them in the best healing mode ever, because they come in after a weekend of drinking. Look, doc, I came in, I had a bender, I just had drinks all weekend long. I'm ready for my shot, and you're like, I don't know if you're the best right now for healing. Do you give them any kind of counseling or information to help?
We don't often have the luxury of time, because it takes some time to kind of prime the road or pave the road. One thing that I will say, though, that another thing we're very interested in would be looking at the hormone axis. If someone's hormones are in the toilet and they have metabolic syndrome, that is not an optimal environment to take cells or put them back in. So, but fixing a hormonal axis takes some time. So again, there's lots of things like that we're interested in, and we want to park as much data into the database and churn and burn as we can. But we have to kind of do it one step at a time, or you can kind of lose your way. But hormones, inflammation levels, and inflammation control probably would be the second. If we have a better inflammation environment, obviously that's best for health as well as the therapeutic capacity of the cells that we're going to harvest.
Well, Dr. David Karli, I really appreciate you coming and talking to us today.
Thanks.
Where can people find you? Social media or your website? What can they?
Yeah, just my name. I'm very Googleable.
Okay.
I'm very searchable. People know more about me when they come than I do sometimes. Instagram, David Karli at David Karli. KarliHealth.com is our clinic, Karli, KarliHealth.com. And our biotech company that's doing all this research is Greyledge, Grey, Greyledge Biotech.com. Lots of information on there for patients to learn us as well.
Awesome.
You have to be an educated consumer these days, know what questions to ask.
Well, thank you so much for joining us today.
My pleasure.
Appreciate it.
Look forward.
Okay guys, if you missed Chicago, if you missed Los Angeles, it's okay, no panic, because we have the same event in Miami early November. Really come, it's an amazing community. We learned so much, and even so, even if you think you're a biohacker who knows everything, believe me, you will learn something in Miami.